Recording, please.
Very good. Well, welcome everyone. Welcome to our our May 24 meeting. We last met in March, and so it's good to see everyone. I think by now many of us might have become vaccinated, and maybe we're even starting to walk out and about and see other people in a house or a restaurant, or maybe not. But in any case, I hope that you're finding some freedom and peace out there, and that everyone is staying healthy and well. And I thank you again for finding time and commitment for this work. And I want to thank Sarah and all the staff for preparing such a great packet. Before we get started, we do need to do a roll call to make sure that everybody who said they would be here are here, so we can get that recording. Sarah, you have a much broader view generally in many respects. You want to lead us through this?
I can do that. Although I'm going to cheat. I have a list. So.
Yeah. Okay. Well, that's why you got the broad view. Why don't we start?
All right. Jack Friedman.
I'm here.
Kevin Iwancina.
I am here.
Patrick Allen. Craig Anderson.
Here.
Catherine.
Here.
Angela.
I'm here.
Bill.
I'm here.
Jessica.
Here.
Mary Beth.
Here.
Felisa.
I'm here.
Ryan.
Present.
John.
Hello, here.
Mark. William. Jordan. Ken.
I'm here.
Shannon.
I'm here. I'm here.
Thanks, Shannon. Scott. Andrew.
Good morning, everyone.
And Jen.
I'm here.
That's everyone. Back to you,
Okay.
Jack.
Well, great. Maybe those who are not here may be coming later. We don't know, but we have a quorum, and that's great. Before we look at the March minutes, I did want to take a moment and recognize Jen Wielander, who is leaving St. Charles Healthcare this summer. And I believe, Jen, you are going off to become a teacher or a professor and teach all the wisdom that you've shared with us. And I just want to say that we have so appreciated your participation and all of your comments. And I'm sure St. Charles is not going to be happy to see you leave, because I know you've done a great job there. And so on behalf of the board and everybody, thank you for your commitment and for your participation and all you've done to advance this work. We really appreciate it, and we wish you the best of luck. Why don't you tell us what you're doing before we get moving here?
Yeah, great. Thank you, Jack. I appreciate it. Sorry, my Zoom is not working. I'm trying to get on, so I'm just on a phone right now. I am leaving. I will be joining the faculty full-time at the University of Oregon in the School of Accounting and be an instructor teaching and hopefully inspiring young accountants to take on this type of career. So this has been a dream of mine for a long time, and I'm just really excited for this second chapter in my professional career.
Oh, that's wonderful. Well, we're glad you're staying in the state, and the University of Oregon needs talented instructors. So they've got one in you. So thank you. And we wish you all the best. And maybe we can seek your advice now as a true academic and not just a regular old CFO.
That's right. That's right. I'll have a different perspective.
All right. Well, wishing you all the best. Thank you again for everything you've done for us.
Thank you.
Mm-hmm. All right. So have folks had a chance to look at the March meeting minutes and such? And is there, can I get a motion to approve them? Any discussions or any comments that people have?
So moved.
We have a move from Felicia, I think. Thank you, Felicia. Any discussion on these? Any clarifications needed? Okay, hearing none. Can I get an all in favor? We'll just say we don't even do this, do we, Sarah? I think we're just going to say there's no opposition, so the minutes are accepted. Now let's move on. All right, great. Thank you. Let's take a look at the agenda for today so we can just make a quick review on this. And we're going to take a look at our revised charter. There was some dialogue about that last meeting, and you have a copy of that in the packet that Sarah sent last week. We're going to get implementation updates from Jeremy and Sarah, I suspect, so we know what the technical committees are doing as we are, advancing our work. We're going to also talk about a framework for monitoring these updates, and we'll chat about that so we know how to get the best information as quickly as possible. And then we're going to talk a little bit about cost growth mitigation strategy priorities. We talked about this in March, and noted that Rhode Island had developed a process, and I think Michael and Megan are going to take us through this, and we can have some dialogue about how do we prioritize new evolving ideas that we think we know about and have heard about, or the data suggests would help us mitigate our cost trends. There needs to be a way to surface that and maybe incorporate that into our work. We will take a break. We'll get a 10-minute break. And then a public comment will be available from 10 to 10:10. And then we're going to review the Oregon Health Insurance Survey data, some of the highlights which were in our packet. And then we'll try to wrap up. I think there's a very good chance, by the way, that we could get out early. I think, Jessica, you said you've got to leave a half an hour early. I think if we run a good meeting, full participation, we may be able to get out of here closer to 10:30 than 11. To give you all time. So that is the agenda for today. Sarah, have I missed anything?
Can I make a request?
Yes, John, please.
So that we might not have time for this, and people might not be prepared, but in part 5, there's two things I'd be interested in. One is there's recent data that showed that Rhode Island and a couple other states that have benchmarks missed their benchmark. And so how we think about that would be helpful. And the other is that now that this is becoming more public, I'm getting requests from my health system and others about how to think about this. And I think I can respond on my own, but I think it might be nice, to have a standardized a way to respond. If a hospital is thinking about this, how serious should they think about it? What are the right ways to think about that? I mean, I think we need to help them make adjustments here. I have my own ideas, but I think, it might be good for the group to have some standardized response.
Yeah, that's a great insight, John. I faced the same thing with requests. So Sarah, maybe in that section, we can find a little time to talk about how, as a committee or as individuals on the committee, we do respond to industry requests for understanding this better and how to prepare for it. There could even be a consulting opportunity for some of us on here. I'm kidding, but I mean that there is that is a common theme that I'm picking up as well. So thank you, John. Good. Other comments on the agenda? Okay. Well, we will proceed then. Thank you. All right. Let's see. What else have we need to look at? I guess we need to now revise our charter. So, or approve the revised charter. Can we get have people had an opportunity to read the charter? You saw some of the new language in there. I believe that was in red, if I'm not mistaken. Are there comments about our charter, and does it feel like it meets the work and is accurate in describing who we are and what we're about? Any thoughts?
Just a clarification. This is Brian. Just a clarification on that the second paragraph. The first context paragraph, second paragraph reference Oregon. The second paragraph doesn't. It's to me, it's more of a, it's a national trend around overuse. And my understanding, actually, in the state of Oregon, that we actually don't tend to overutilize. It's really a rate issue. So I'm just thinking that maybe a clarification of some wording around nationally, approximately 25% of total healthcare spending, something along those lines. It is at least not my understanding in the state of Oregon, we got that amount of, unneeded healthcare spending, unused utilization.
Yeah, I don't, we can debate that. I don't know if John, you look at this work pretty closely. I think the data, Brian, have shown that in Oregon, we are below average in our use rates. I think it was 9%. There was some data that showed some years ago that we were hovering at about 9% below average. But if the truth is that we're, 25 to 30% of utilization is sort of wasted, there's still plenty of opportunity to reduce use rates in the Oregon market. But it's not as big a driver as the per unit cost, particularly in the commercial market. So I don't know how we want to address that. John or John, you study this stuff. Any thoughts there that you'd weigh in on?
I mean, I think that's probably right. I mean, I think this is more of a rate issue than a utilization issue. I guess I see this as sort of an opening framing of the problem, and so it depends on how precise you want to get on that front part.
Yeah, I don't know. I'm reluctant to want to give us too many good grades here. There's plenty of clinical waste reduction opportunity and plenty of administrative waste reduction opportunity on the payer side. So I don't know, Brian, if you, maybe are there some others that would weigh in here?
Looks like Kevin and Bill both have their hands up.
Yeah, Kevin, why don't we go to you and then Bill? Oh yeah, Bill, we need to hear from our actuary. Oh my Lord. Okay, let's go to Kevin first because he's a doctor.
Yeah, I just quickly wanted to point out that the low value care report that Oregon Health Authority and Oregon Health Leadership Council put together last year did show that there was a high spend on procedures that brought low value to health outcomes, but had a significant cost associated with it.
Mm-hmm. Okay, so you're saying there's opportunity?
Absolutely.
Yeah. Bill, thoughts from Kaiser?
Yeah, not on this particular issue. I'd raised my hand earlier, so I don't know if you want to table this to later. I
was hoping as an actuary you'd be weighing in on this, Bill. My Lord. You can say whatever's on your mind, please.
Well, so as an actuary, of course, I'm going to go with wording. But on the implementation committee charge on that second bullet on page 2, we just used the term unintended consequences. And we had a lot of discussion at one of the prior meetings on changing that to negative consequences. I just wanted to bring that up sort of as a wordsmithing item.
Yeah. Okay, good. Let's return. Brian, thoughts? I mean, would you be satisfied with keeping the language as is, or do you have a recommendation?
Well, I just, again, I am off mute. Sorry about that. To me, it's really referencing a national stat in the first paragraph and third paragraph reference state. It just sort of feels like it's in context unless someone looks at the footnote. It's it comes off as a state at 25%. So I would just add nationally, approximately 25% of total health, just for accuracy.
Yeah. Okay.
But I'm not going to fall on my sword for it. I just
right. Gotcha.
It didn't sync up for me.
Yes. Okay. Well, noted. Sarah, can we make a note on that?
Yes, so I've heard two changes, the nationally, comma, approximately, and the unintended consequences to negative impacts language.
Yeah.
And
Mhm.
Catherine has her hand up as well.
Yes, Catherine, please. Catherine, I think you're on mute.
I just couldn't get it off mute. As I said, I start off in the morning being real soft, and somehow my iPad doesn't receive the jab that it needs to open up. But anyway, I have a question, not a comment, but in the second section at the top of page 2, I believe it says, with the expansion, provide guidance for healthcare cost growth target program implementation. And D, develop recommendations for strategies to slow cost growth and support cost growth target attainment. It's that D part that I think we're expanding specifically, that we had conversation about last meeting, and we'll have specific conversation about it today. And I'm wondering the process used to what we do with these strategies and how beholden we are to implement the strategies, given that we already have a target and a recommendation for implementation of value-based contracting. And so I think we need to revisit that as we discuss the process for, if we're going to do this work of developing recommendations, what happens to those recommendations? So I understand we've expanded the committee's charter. I don't know what we do with the work of that part D that we added to that last sentence. It says develop, and I just, as we talk about that today, I'd like to make sure we circle back to this particular paragraph.
Well, yeah, I mean, we may be picking that dialogue up, Sarah, wouldn't we, in the mitigation strategy prioritization? Is that where we would capture some of that dialogue?
Yes, we're going to have a whole discussion about the process and what happens with recommendations, or what recommendations even look like for this next phase.
Okay, so let's hold that, Catherine's thought there, as we try to understand what a good process will look like there.
Thank you, Jack.
Yeah. Okay, good thought. Other comments? I think we do want to get eventually we want to get a motion to approve this charter. So we have a good, final draft. Sarah, I know you'd like to kind of get this moving. If we were to propose some edits one more time, incorporating these thoughts and what's to come throughout the rest of the morning, you think we could get a final draft out in next week, maybe? Do you want to get this approved in July, or would you like to get it approved by email?
I think if everyone's comfortable with the two changes that have already been proposed, and then a placeholder for Catherine's question later in the meeting, maybe we can check back in on this at the end of, before we wrap up today's meeting and see where we are. We might be able to get to approval today without having to do another full round of edits.
That would be my hope. And if I'm here, if I'm hearing no opposition, why don't we see if we can't thread that needle? Okay. All right. So no other comments on the charter at this point? All right. Well, thank you all very much for weighing in. Appreciate it. Okay. We're going to, Sarah, I think you're going to walk us through slides 9 through 14, which I hope you'll put on there so everybody can see them as you're talking, because that kind of helps, I think, and give us thoughts on how we are going to kind of monitor updates and keep everybody informed, right?
So Jack, I think we're skipping over a couple of updates first. So
we are.
I think we're going to go to Jeremy for some general implementation updates.
Yeah, I'm sorry. My bad. Excuse me.
No worries. We'll go to the next slide. I'll give a quick couple of implementation updates there. Please feel free to add some details here if I forget any. We'll go to the next slide. Great. So Sarah's been staffing the technical advisory group that's been working on data since the beginning of the year. They meet again this Wednesday. They are on track to have final specs for data submission done in June. We've actually filed temporary rules. They aren't live quite yet. Will be shortly, and we plan to let mandatory data submitters know starting today who they are and what the specs are for filings. So for those who are insurers on the committee, your teams will be getting a notice here shortly. And we'll talk a little bit more about this at in the next agenda item of the framework for monitoring. We'll get a little bit more into the details here. The accountability bill, House Bill 2081, passed the Senate on May 10th, is on the governor's desk for signature, passed both chambers with really broad bipartisan support and no opposition. The value-based payment compact, I want to go to the next slide. I think we've actually got a slide on this.
Jeremy?
Yeah.
But without going into too much detail, do you have a moment to let the committee know exactly what the key components are of 2081 so we can have a refresher on that?
Sure. So House Bill 2081 really just implemented just the accountability piece of the program. So that lays out the framework that beginning in the second year of the program, organizations that are above the target could be on a performance improvement plan beginning in 2026. Organizations that are above the target 3 out of 5 years could have a escalating measure of a variable financial penalty. It also includes kind of normal, I shouldn't say normal, the kind of fine process that we outlined for the committee for data submission that's separate from the penalty piece of being over the target. But that was really the framework that was in the bill, just that accountability piece. It changed some of the language from referencing the program as a benchmark to a target, because that's the term that we've been using, but otherwise it was just that accountability piece.
Yeah, good, very good. Okay, thanks.
Let me go to the next slide. I think we shared most of this last time, but just a refresher. Excited that we've announced the value-based payment compact. We've had 45 organizations sign on across Medicaid, Medicare, commercial, and state payers. Overall represents on the payer side represents 71% of the state's population, which is pretty phenomenal. We've not seen a compact like this or a commitment like this anywhere else in the country, and got some good press on it. As folks will recall, we're doing this work in partnership with the Oregon Health Leadership Council and co-hosting the work group. We've been finalizing the work group names, and the first meeting will be on June 30th. And it's a little hard to see on the slide, but at the bottom there's a link to the Oregon Health Leadership Council's website where materials and information will be posted about the work group. So one of the first things that the group will be looking at is recommendations for how we communicate out to organizations who haven't signed and continue to invite folks in, but really excited around the progress of this. Next slide.
And Jeremy, can you just let the group know, the work group, I'm assuming is composed of representatives from the payer world, provider world?
It is, Jack. Yeah, it's I'm blanking on the exact numbers at the top of my head, but we basically mapped out that there was 3 seats for OHA to appoint, 3 seats for the Hospital Association to appoint, 3 seats for the Medical OMA to appoint, 3 seats for the Health Leadership Council to appoint, and a couple of kind of at-large members. So we're pretty close to finalizing that list of names, and have been trying to really strike a balance of making sure we've got representation from across the state and hitting key stakeholders in the process.
Okay, and then finally, if I could just ask, are we hopeful that this work group can come up with 1 or 2 preferred models that could be, sort of certified as truly value-based by what, the end of the year?
Yeah, so the group is really going to be focused on kind of implementation strategies. So we had a long discussion around whether they should be coming up with, like, the preferred models, and decided not to start there. Although I think there's a general goal of not having, trying to limit the complexity in this, but weren't sure that we're in a spot where we could say we want to have 2 models or 5 preferred models. Certainly the work will all be based on the land categories, and there's standards within that for what counts for upside down risk. Population payments as an example. The group's really going to be focused on monitoring implementation and trying to identify challenges and ways that we keep payers and providers working together, and if there's barriers that we're running into, that we figure out how to address those. An example that has come up in this committee and has come up with in our early conversations about launching this work group is the need to have primary care assignments as an example of, as we're moving into value-based payments, especially value-based payments that are based in some way on primary care attribution. So those are the types of issues that will get surfaced, and the group will make recommendations back to the organizations that sign the compact and to the state and health policy board on how to address those.
Great, awesome. I have one more. I'm sorry to keep asking you questions, and my only other comment would be, most payers and providers begin their dialogue around risk contracts in the summer for the upcoming calendar year. And so it sounds to me like we may not have a lot of detail to share for the 22 calendar year, which means the contracting, session tends to be, I'm doing this, there are other people who know this better than I do, but let's say June through October. Whatever we could do there to try to advance the thinking for the 22 calendar year would be helpful. And I don't know if the committee's thinking that way or not.
Yeah, I mean, they haven't launched yet, so they aren't there. And I mean, the goal, this isn't to be regulatory in nature, but really more technical support. I don't know where folks are at. Something, and I don't know if Ken or others on the call have a sense of what the conversations are like out on the ground. I've certainly heard that the cost per target generally is coming up in provider contract negotiations and discussions, and so is the value-based payment compact. So I suspect it's out there in the discussions, but would look to others to see if they've got any.
Yeah, I would say, Jeremy, that's true.
Okay, good. All right.
I would agree.
Good. Okay. All right. Thank you, Jeremy. Sorry to.
No problem.
Okay.
And then last update, we are still really excited to be part of the Peterson Milbank program for sustainable healthcare costs that launched a couple months ago with several other states. We're starting just this last week have started regular calls with those other states. We're kind of the 5 states that are launching these programs, we're the farthest ahead in implementation. So it's been a lot of us sharing our learnings, but are really excited to be part of that process and learning from their states as they launch this as well. We've also had a call recently with CMS that's also been monitoring this and paying attention to it. So I'm excited that there's some interest at the federal level from this administration on supporting states that are launching total cost of care target programs. We've also started separate from Peterson Milbank. Washington is part of that program as well, but we've also started some separate monthly calls with Washington. They passed legislation to create a cost per target. Their last session, they've started up a stakeholder committee, much like this committee, and are staying in close contact with them. I think we share a common goal of trying to align wherever we can. We have certainly some provider overlap, but especially some payer overlap with that significant payer overlap with that state. So I want to try to align wherever we can. Yeah, I think that's it for my update. Sarah, did I miss anything?
That's it. Thanks.
That's excellent. Thank you very much for the updates. Okay, now, Sarah, sorry about that. Do you want to chat to us about how we're going to be monitoring the progress of our various groups?
So I think this is probably on me and the way I framed this on the agenda. So the framework for monitoring is its own thing. It's not a framework for monitoring updates. I'm giving you updates on the framework for monitoring. So sorry for the confusion there.
Sorry.
So wanted to follow up on where we were with the framework development and some of the upcoming steps for this summer. And just to remind you back to last year, this is all work that came out of the quality and equity work stream, and you all recommended 3 primary strategies for this work. So the first is reporting on a standard set of quality measures. The second is monitoring activities around potential negative impacts of the cost growth target. And the third is more proactive strategies and looking for additional opportunities where action could be taken to improve equity. So both looking at quality and access and monitoring for negative impacts, as well as a more proactive approach. So we've been working with several other committees of the Oregon Health Policy Board to begin developing out these strategies and start figuring out what this actually looks like for ongoing reporting or ongoing monitoring. And we've been compiling all of that discussion, decision-making with the other committees in the document that we're calling the framework for monitoring. Next slide, please. And we talked about this a little bit in March, but the purpose of that document is to provide the structure and the documentation. It's a living document that clarifies the interactions between the committees. It really helps layer in each piece as this conversation is happening in multiple places, keeping it all pulled together so that we have a cohesive look at what we're doing around the quality and equity work stream. We'll continue to update this document with measure details, data sources, specific plans for reporting as those details are finalized. And then this is complementary to the data use strategy. So as we've talked about a couple times before, there is a whole body of work around what we're measuring and reporting on about cost trends and cost growth drivers. And we'll be looking at all of that sort of under the data use strategy umbrella, not under this framework for monitoring quality and equity umbrella. It's completely interrelated, but we've been trying to silo it a little bit into the work streams just to make implementation conversations a little bit easier. Okay, so let me tell you where we are with the first 2 strategies. Next slide. So for reporting on the standard set of quality measures, we've been meeting with the Health Plan Quality Metrics Committee. We met with them and had some really good discussion in March and April, and we'll have hopefully our final conversation with them tomorrow. Their charge was to look at their existing aligned measure menu set. So this committee every year develops a menu of aligned measures to be used in various state programs. And so they already had a really robust measure set, and we thought we would start there to come up with the standard set of quality measures for the purposes of the cost growth target program. We asked the Health Plan Quality Metrics Committee to look at their existing measures and consider if they were appropriate for cost growth target monitoring from, again, that quality and access lens. We really talked with them about having a do no harm lens. So as payers and providers and stakeholders are taking action to meet the cost growth target, we want to make sure that quality and access is not being hampered or hindered in any way. And that was their initial charge. We also recognize that the Health Plan Quality Metrics Committee really focuses on measures for Medicaid and commercial. Medicare measures were a little bit newer for them. And so we also identified the need for some supplemental measures to make sure that we did have some measures for the Medicare perspective as well. So next slide, this is the draft where the conversation has landed. But of course, this is pending discussion and hopefully final approval tomorrow. So we're looking at a subset of measures from their menu sets, again, focused broadly on quality and access. So you'll see a couple of utilization measures here. You'll see a couple of preventive care, preventive service measures like colorectal cancer screening and statin therapies. And then last month, the Health Plan Quality Metrics Committee had some really good conversation about there needing to be some broad behavioral health utilization measures as well. That was an area they were particularly interested in, making sure that we weren't monitoring just access to physical health, but also to behavioral health. So we're going to be discussing tomorrow 2 measures mental health treatment penetration and substance use disorder treatment penetration as potential options for that behavioral health utilization. And then you can see which of the 3 markets, Medicaid, commercial, and Medicare, the measures would apply to. And just as a reminder, the intent here is that OHA will be producing these measures using our all payer claims database, and we'll be reporting on this at the state level in conjunction with cost growth target reporting. This, as a measure set, is not intended to trickle down into contracting. It's not replacing any of the other measure selection programs or other quality mechanisms that are tied to measurement. Not yet. Go back to the measure slide. I'm going to stop there for a second. Any questions or comments about the Health Plan Quality Metrics Committee discussion so far?
Sarah, can you just comment on, like there's a couple here that are what I typically see standard measures like breast cancer screening, maybe cervical cancer screening. So clearly everybody knows those are common. So then they're not on this, just kind of the logic behind them not being on this set. Yeah.
So one of the other parameters we gave to the Health Plan Quality Metrics Committee for their conversation was that these measures needed to use existing data sources, which really we're talking about the all payer claims database so that we could measure across market. So we needed measures that could really be produced with claims, and breast cancer screening measure, the cervical cancer screening measure, and a number of other standard HEDIS quality measures are hybrid measures. They require electronic health record information to produce in full. And we did not want to create new reporting burden for payers or providers with this monitoring work. And so those were taken off the list. There was discussion about them and the need to continue to monitor those preventive type measures. And I think there are some other existing reports that can potentially be tapped into, but they didn't make the cut for this full set. The one exception here is colorectal cancer screening. There was a lot of discussion about the importance of colorectal cancer screening, particularly given some of the known disparities in the state and the applicability of this to all of the populations. Colorectal cancer screening is technically a hybrid measure as well. You should be using electronic health record or chart data in that. There is a way to produce it with just claims. It will be a known undercount, but the Health Plan Quality Metrics Committee felt that it was more important to have that on the list despite the limitations of that undercount methodology.
Craig has a comment or a question, Craig?
Yeah, thanks, Sarah. I just want to put this in context on how quality measures are going to be used, because they use it in a number of different ways, but this is really intended, if I understand, to create a baseline and then ensure we don't have negative impacts of the cost containment work. So this will be, the reason I'm asking it that way is, so we'll measure that over time, but it's not necessarily meant to compare entities against each other. Is that right?
Correct. We're not setting a benchmark for these measures like we do in other quality programs. We're not comparing entities against each other on their performance on these measures. This is to look for those potential negative impacts or to make sure that we're not backsliding.
Right, but I assume that if we do see some backsliding, we would go into that and see where that's coming from. And that's how that would probably come about.
I think this is part of the conversation that we haven't necessarily had yet, is what do we do once we look at the results of the framework for monitoring and do see those problems. And maybe some of this is part of the conversation we can have about strategy prioritization, Michael, but I think some of it is a broader conversation about whose role is it to intervene in this. Is this something HPQMC should be monitoring? Is this something you all should be monitoring? Is this something that should be reported back to the policy board? I don't know that we've pinned down who should take action if we see backsliding in quality and access.
Okay, thank you.
Hey, Sarah, just real quick, can you give me just the definition of like the hybrid measure, what that means?
Hybrid measure uses 2 different data sources, usually medical claims, administrative data, and then medical record data, whether that you get that directly from an electronic health record or you do a manual chart review where somebody actually goes and combs through looking for the details.
Okay, thank you.
John, did I see your hand up?
Sorry,
Lisa's got her hand up too.
Yeah. Okay. Elisa or Felisa, please.
So Sarah, I have a question about the sort of if these are the measures that we're using for backsliding and our only ability is to do claims measures, then how are we going to disaggregate the data so that we can see if there are particular populations we're backsliding in, is my first question. And then I think that I assume somewhere in the work plan, which I believe is this constant discussion that consistently happens, is how do we move from claims data to clinical data at some point in our lives together so that we can actually dig deeper into these measurements and data.
Yeah, and
so if you could just address the work plan issue and then the disaggregate issue, thanks.
yes, and I don't want to get too far out of my lane here because there is a whole body of work around measurement and what we're doing in that broader work plan. And our lens for the cost growth target program and this monitoring is just a tiny slice of that broader conversation. I think as we move as a field and as we move as a state towards being able to have more of that clinical data, we will of course pull that into the cost growth target program, but we're not trying to have the cost growth target program solve that for the state. So I think it's a known limitation we're trying to work in, and there's a broader effort to try to address it. To your first point about disaggregating, there are a couple of options that we have been talking about. There are ongoing activities to improve Real D data and pull that into the all payer claims database. Anything that is added there would obviously be available for disaggregating these measures and that analysis. We're also talking about some additional variables that we do already have access to, so age, gender, geography, and we intend to disaggregate in those ways. And then there are some additional approaches that others have used successfully that we're considering, which, for example, pulling in American Community Survey data and mapping to census tracts and using that to help create some additional insight into the claims data if you don't have that on the individual level. So none of those are sort of the perfect solution for having incredibly detailed data for each individual in the database, but there are some proxies that we can apply to be able to disaggregate the data and give us some direction.
Okay. Sarah, I was curious, were diabetic management controls ever considered, given the impact it has in the commercial population on total cost of care?
Those measures are on the menu set, and a couple of them can be produced with claims only, so they made the cut for discussion. But the general thinking was that it's more that measures that focus on smaller populations, especially when you start thinking about specific diseases and people with specific conditions, you narrow the population pretty quickly. And the Health Plan Quality Metrics Committee was looking at measures that would have a very broad inclusion criteria for these purposes.
Okay, all right. All right, other comments about these measures? What is there an action here? Do we want to approve these, or what do you think? Yeah.
The Health Plan Quality Metrics Committee hasn't even approved these yet. This is just a preview for you. They'll be finalizing this hopefully tomorrow.
Okay. Is there any more input for Sarah to pass on to the committee? Anything that people have not said that you'd like to say? I'm not seeing anybody. Sarah, are you? Okay. So timing wise, we'll be back. What does our committee even have a role in approving this? Is that part of our job here, or is this just an FYI?
This is just an FYI. Your recommendation last year was to move this work forward with the Health Plan Quality Metrics Committee. So they'll have the sign off, and then we'll move forward into the work plan of actually figuring out production and reporting on these.
Okay. All right.
We can send you an email after the committee meeting tomorrow and let you all know where this lands, if that's if you don't want to wait till July, but I don't think there's an action I'm looking for.
Okay. All right. Well, we can, yeah, that's not a bad idea if you think about it. Sure. Yeah. Okay.
Go to the next. Sorry, I have one more update in this section, Jack.
Yep, good.
The second strategy about avoiding negative impacts of the cost growth target, your recommendation was that body of work should be developed with the Health Plan Quality Metrics Committee and the Health Equity Committee. So we've been having conversations with the Health Equity Committee over the last couple of months. And this one is this started as a much more open-ended conversation. So you originally had some ideas about what potential negative impacts could be. So those are things like the consumer out-of-pocket costs, consumer cost sharing, and what was happening there. Potential negative impacts on the healthcare workforce. So where salaries, benefits, hours, anything like that being cut as part of cost containment efforts. And then there were a couple of other ideas, but it wasn't as concrete as here's a list of measures, pick a subset. So this has been more of an evolving discussion. And Michelle, next slide, please. When we talked to the Health Plan Quality Metrics Committee, when we talked to the Health Equity Committee last month, they really expressed some concern back to us about this passive do no harm frame. And that monitoring for backsliding or monitoring for negative impacts just may not be sufficient, and that this is really heading in the wrong direction. And they talked about the spectrum where really do no harm is a neutral perspective, and that's just not sufficient, and that they want to see us moving in this program moving into more proactive improvement. So they are asking us to continue to think about more proactive ways to improve equity, move us to the 10-year goal, to OHA's 10-year goal of eliminating health inequities. And how can the cost growth target program play a role in that? What are the levers that the cost growth target program has for this? So we're going to come back to the Health Equity Committee in July and continue this conversation with them. And they really want to make sure that we're not just talking about what are negative impacts to avoid, but what do we want to pursue and improve. And I think this is a place where, again, the cost growth target program has a slice of this work, and we're trying to find that right balance and overlap where it's also not the charge of this group or of this monitoring for negative impacts or even taking proactive improvement to solve all problems. And I think it's really easy to come up with all of the things that are in the current system that are doing harm or that might cause harm, but then thinking about, again, just as you were saying earlier, whose responsibility is it to take action in some of these steps is a more complicated conversation. And so I think we're going to continue to try to balance that conversation and some of those tensions about how far upstream something should be, what is the role of the cost growth target program in that, and where are those opportunities for proactive improvement. So not as much of a concrete context to report back to you, but did want to let you know about some of their initial reactions to this framing and where we're going for the conversation in July.
Great. Okay. Any comments for Sarah? Thoughts? Okay, thank you very much, Sarah. Appreciate it. All right, I think we're now going to turn it over to Michael and Megan, who are going to kind of walk us through how we kind of monitor emerging, cost mitigation strategies, and how those have been maybe incorporated in other states that have been focused on this kind of work. So Michael and Megan, welcome. Always good to see you. Why don't you take us through what you've learned and maybe how we might learn from others?
Thank you, Jack, and good morning, everyone. First, before I start this conversation, I just want to acknowledge John's request much earlier in the meeting to reflect on Massachusetts and Rhode Island's experience and advice on hospitals or what to do. I think, John, you had suggested we talk about this in this portion of the agenda. I'd like to suggest that we go through these slides first, and then if there's time and interest, we can talk about those two topics, but that we begin by talking about what we've got slotted here. Was that okay with you, John?
John, does that work okay?
I'm giving my thumbs up emoji.
Thank you.
Okay, thank you for that.
Okay, so I want to provide a little bit of context with the diagram on the next slide for the conversation. This slide is really the logic model for the cost growth target as a strategy. The cost growth target in and of itself is not the end, rather it's a tool to try to promote slowed growth in healthcare spending. And so where we are right now, having established the target, is to begin to take some steps to measure performance relative to the cost growth target. And Sarah talked about the technical advisory group and beginning to put together some rules related to reporting. What follows if we go around this diagram clockwise is that the measurement of performance of the cost growth target is supplemented by what we've been referring to as the data use strategy, which is mining APAC and other data sources to get some insight into what's causing spending to grow and what's causing spending to be perhaps higher in some areas and lower in others. The third step is then public reporting. We've talked about this extensively in the context of the cost growth target. We haven't talked about it really with regard to the data use strategy in much detail, but the idea is that both performance against the cost growth target and analysis of cost drivers and cost growth drivers would be disclosed, certainly to this body and its successor, as well as to the public. And then with that information, there would be some identification of where there might be opportunities to slow cost growth. And this is where the cost growth mitigation strategy prioritization process that I'm about to talk about fits in, because between identifying opportunities and implementation of strategies, that green circle is a prioritization and deliberation process on the part, again, of this body and of its successor. And so what we are talking about today, following our conversation in March, is once there are opportunities identified to slow healthcare spending growth, how are their decisions made in terms of which ones to pursue? You as a body have all endorsed advancing adoption of value-based payment as one strategy, but I think there's an assumption that that won't be the only strategy. In fact, that wouldn't be sufficient in order to sustainably slow spending growth. And so what we're talking about today is what might be the process for considering potential other strategies as they might emerge. So what I want to do is talk about first how the strategies might be, what would be the criteria for deciding which strategies to advance, how might they be identified, and what would be the process for prioritizing them. Okay, so you can think about this prioritization process as fitting between the implement and identify circles in this logic model. Any reactions or questions? That make sense? Okay. All right, so let's go to the next slide. So potential opportunities to slow healthcare spending growth are likely to emerge from a few different sources. One will be reviewing data, both cost growth target performance data, as well as the data use strategy and deep analyses. Two, payer and provider organizations, including those represented on the implementation committee, are likely to bring forth some experiences and ideas and suggestions. And then finally, a broader group of stakeholders, both on this body and sitting outside of the committee, may identify potential policy opportunities. So there are multiple paths, some directly resulting from data analysis that's part of the work of the cost growth target program, and some coming from other sources. Next slide, please. So in March, I shared with you criteria that Rhode Island has adopted to vet cost growth mitigation strategies. And in fact, they've now used them a few different times to decide what gets thumbs up and what doesn't. We then reviewed with you potential prioritization criteria for your adoption. You provided some feedback, including some suggested modifications. And so what I'm going to share now are modified criteria that reflect your input, as well as a more fully developed description of the process that strategy identification and prioritization would follow. All right, I'm going to start first by reviewing the revised criteria, and then I'm going to describe the process. I also want to note that both the criteria and the process are likely to evolve over time as you have experience using them. I have no question that as you start doing this work over time, that you'll decide that you want to make some tweaks. But this is a suggestion for how you would proceed for right now. I want to note that you received prior to this meeting a separate standalone document that's 3 pages long that provides what I'm going to share in summary version on the next few slides in more fully developed prose. And if you want to reference that document while we're talking, I would encourage you to do so. Okay, next slide, please. So these are the revised proposed criteria. Again, you can see them more fully developed on page 1 of the document that was distributed with the meeting materials, where the language is a little bit more expansive and includes some definitions. So this is not wholly different, but reflects a little bit of refinement. There are 4 criteria. The first one is that spending data indicates there's a significant opportunity, and significant opportunity is identified as recent spending has been in excess of the cost growth target. So for example, when you measure cost growth target performance, let's say you looked at pharmacy as a broad category and it was growing at 7%. So you might say, whoa, that's way above our cost growth target. So that represents an opportunity. Significant opportunity also means that there's significant variation in spending and utilization across the state, and that would be revealed through the data use strategy, because the data that comes in on the cost growth target will not provide that type of nuanced view, but variation suggests that there might be opportunity. And 3, spending or service utilization is above external benchmarks. So let's say you have experience from the Healthcare Cost Institute or from other cost growth target states, say the Peterson-Milbank states that Jeremy referenced, that they're doing their own measurement and reporting, and we find that Oregon looks way off compared to the others. That might be another indication of a significant opportunity. The second criterion is that successfully addressing the opportunity would have a substantive impact on cost growth target attainment. Substantive impact is defined to mean that taking action would result in a measurable reduction in cost growth. So sometimes you might find that there's an opportunity, but if you addressed it, it wouldn't really move the per capita healthcare spending growth rate. And so that would be assessed as not substantive. So it's got to make a difference, the strategy. And I can share with you that in Rhode Island, they were looking at pharmacy strategies earlier in the year, and they had a couple of options. And they judged that one of them really wouldn't have made a big difference on trend, but the other one would have. 3, there's published evidence that supports the strategy, but if there's not, there's a compelling logic model that supports it. And this recognizes that evidence that the strategy is effective should be an important consideration. But to the extent that you are considering a strategy that hasn't been pursued before, it allows you to prioritize it if you find that the logic model supporting it is a super compelling one. And then finally, there's capability and capacity to implement the strategy. This is at the plan, provider, DCBS, and OHA levels, and frankly, anybody else who would need to be involved. And then in response to, I think, a suggestion from Ken at the last meeting, we added that the required resource investment would not detract from previously prioritized strategy design and implementation. So that's the revised set of criteria. And I'd like to pause now and ask for your feedback.
Can I ask, I think that you're going to talk about the practical implementation of these strategies. So can we, I guess I have some concerns about how some of these are worded, but they may be addressed in the practical implementation.
Okay, so do you want to go through the process first and then talk about them?
and then circle back if that's okay. Yeah.
Sure. Okay. So unless anyone objects, we can talk about the process by which they'd be applied and then come back and talk about whether you want to make any modifications to the criteria. Okay, next slide, please. So our proposed process is 3 steps: identify the strategies, assess them, and then bring them to the committee for consideration and recommendation. So I'm going to start, I'm going to move sequentially through these and start with strategy identification. Next slide, please. So there are 2 possible channels. One, data analysis performed by OHA and presented to you. This is what we've been referring to as the data use strategy, and would involve APAC and potential other data sources. I guess it's possible that there could be other parties aside from OHA that could perform analyses, but strategically, there's intent for OHA to conduct these analyses and to help inform your deliberations. And then 2, as I said earlier, you and stakeholders outside of this body might identify strategy proposals based on considerations. This could be other data analyses, they could be policy papers and publications that you've read that you think warrant discussion at the table. So 2 different ways that strategy, and I mean cost growth mitigation strategy ideas could come to the proverbial table. So then the next slide has the process for assessing them. And what we proposed last time and continue to propose is that the chair, vice chair, and OHA staff would, as a group, assess and score the strategies against each selection criteria individually using this 1 to 3 scale that you see here. There would not be an aggregate score, because to do so would probably overstate would quantify what's a qualitative process and would probably oversimplify the assessment. And because there are only 4 proposed criteria, there's not as much value in creating a total score. So you would see for the strategies that have been presented how this group assess them, and you would see a score of 1, 2, or 3 for each of the 4 criteria. That would just be their assessment. You as a body would then make your own assessment. You might agree or disagree with what the chair, vice chair, and staff have done, but at least someone will, in advance of your conversation, have given some concerted thought to it. Okay. It's possible that there would be multiple strategies proposed for the same opportunity at one time. I gave the example in Rhode Island where they considered multiple pharmacy strategies at the same time because pharmacy was a problem. If there are multiple strategies, they would be assessed against the criteria together and presented together so that you could compare the options in a more effective way. So then after the assessment is completed, next slide, please, it would be presented to you. And on page 3 of the document that went out with the meeting materials, there's actually an example of what the process might look like over multiple meetings of the implementation committee, how this deliberation would work. But presumably this isn't a one-time presentation and decision, but there's some iterative discussion. And your conversation would be whether you want to make a recommendation that the strategy should be pursued by OHA, the Health Policy Board, or the legislature, or frankly, perhaps another entity. It could be DCBS or some other actor or actors. I guess it depends on what the strategy is. But you as a body would make a recommendation for the strategy to be pursued, and by pursued, that could mean a few things. It could be further design before implementation, or it might be that the strategy is so well formulated that it might be, for example, you recommend that the legislature act on a policy proposal during the next session. So we have a bunch of outcomes listed at the bottom of the slide. You could say, yes, proceed. You could say the first time it's presented, we're interested, but we'd like some more research, go find out what some other states have done, or we want some more literature, or go interview some providers of payers. You might say, we like the strategy, but we'd like you to modify it. So come back with a modified strategy. You might decide that the time isn't right. Let's say, for example, you believe that that there are enough strategies that are in place right now that people's plates are filled. So going back to that capacity capability criterion. So you might say, we really like it a lot, but right now we don't have enough bandwidth for it. So let's defer it and come back to it in a year. Or you could say, this isn't a good idea. Does it meet the criteria? And we think that there are other ideas that might be better. So all of these are possible outcomes, and they might emerge after a first discussion or over the course of multiple meeting discussions. Again, depends on what the strategy is and what are the perspectives of the committee. Okay, so Felisa, is that helpful?
I think it is helpful. I think I just have a couple of comments on the overall strategy assessment document that tie to this assessment considerations. So, and the process for assessment. So I think I support the overall strategy document. That my concerns is that on a strategy 2, we don't let the perfect be the enemy of the good. And so when you look at the document around, I'm sorry, strategy 1, actually the analyst is spending that, you know, we get to a 5% total healthcare spending. So I think not letting the perfect be the enemy of the good. There are a lot of strategies that may get you a 1% or a 2% that then could add up over time that take less effort to implement.
Mm-hmm.
And so I agree we should be striving for those 5%, but let's not hold us back from the 1 to 2%, trying to get to that 5%. I think the other thing is the other piece of that is strategy criterion number 3, the published evidence. I agree that we should have evidence or a strategic case to move forward with the strategy. If you don't have a reason why, it's not a good idea to do things typically. But I also think that there should be flexibility, and we should think about pilot projects or set aside projects for implementation, and that we don't have to consistently implement things all or nothing. And so not letting the evidence hold us back from the sort of all or nothing implementation, because the reality is there aren't a lot of published evidence because we haven't tried a lot of different things over many years to reduce costs. Otherwise, we wouldn't be in this boat. I think, and then on the 4th one.
I'm sorry, Felisa, just one thing. In response to your last comment, I just want to note on page 3, there's language that says the assessment, this is the one by the staff and the chair and the co-chair, will include a recommendation as to whether the strategy should be tested for viability before being implemented at full scale. So I think that allows for a pilot option if that's viewed as desirable.
So I think as we're bringing strategy, so as we're bringing strategies forward, we should really think that through as well. So, and then I think on 4, this capacity question, I want us to be really clear. We underestimate the capacity of the healthcare industry all of the time. When something is 15% of the gross domestic product of the United States, it has an enormous and incredible capacity for change, and it has the resources to make those change. Now, the cultural resistance may be there, and that's a different issue that we need to address, but I don't want us to go down a hole where we are held back, because what we have is a lot of people who are culturally resistant to the change that needs to happen, when we know, in fact, the industry can change rapidly and quickly for their benefit, frankly. And so how do we take that same mentality and apply that to the benefit of the consumer?
Those are great comments, by the way, Felicia. I really appreciate your saying that, and I think you're spot on. Thank you. By the way, it's not 15, it's 18.
Missed that 3% GDP growth. We'll see what it is next year after COVID. It's probably up.
Bill has his hand up.
Yeah, I mean, I just wanted to basically the same items that, or at least one of them that Lisa had come up with. On number one, I'm sort of in the same place, maybe for different reasons. And probably it depends on the granularity, if you will, of the strategies. And I think you need to be at a fairly specific level to have it actionable and be able to track it. Otherwise, if you roll it up, you don't really have an actual strategy. The point being, I'm not sure there are any big ticket 5% items out there. And so I think it becomes more a discussion around prioritization based on relative value. So, hey, maybe, you know, I got one that's worth 2% and, you know, two that are worth 0.5%. So we, you know, pick the 2% one. But I mean, even just depending on how you measure it, if you look at pharmacy, you know, I might be able to get 10% savings, say hypothetically, off of pharmacy. That's still not going to hit the 5% off of total cost of care. But gee, I'd rather take that, you know, big bite of that apple that we can if it's an actionable strategy.
Thanks, Bill. Yeah, I just want to know, so there's, just so everyone's clear, there's no 5% rule in here. It just says that that the action would have a measurable reduction in growth. So that's all that it's saying. It's far less than saying it's going to reduce healthcare spending by 5%.
We have some other hands up. Jessica, I think you have a comment.
Yeah, my comment is more around, I guess, the combination of these strategies, meaning that, you know, we may get 0.5% here, you know, maybe 2% there, but combining those strategies in a way that's meaningful, I think could make a combined larger difference, right? Meaning these are not, this system is an integrated system that works together. And so, you know, you change one or two small things and you might really see a collective impact that's larger than what you've assessed for those individual changes or strategies that you're implementing. So as we look at this, I would like to maybe take a look at them and how they impact each other and maybe make some decisions based on that. Does that make sense?
Yeah, I think so.
Craig, you have a comment?
Yeah, thank you. I was just going to comment that I think this, the possible outcomes, I think what that develops is potentially a pipeline of opportunities that as we defer some, they might fall off the list, they might come back on as time develops. So I think I like that process. I think what I want to really ask are a couple practical questions. One is, I think I heard something about the ideas have to go back to the legislature. So maybe you could comment on that. Maybe I misheard that. But what I think where I'm feeling a little bit uneasy is, I think the recommendations come back to a committee like ours. Is that right? Made up of payers and, okay. Mm-hmm. I'll give a practical example. The Oregon Health Authority, on behalf of HEB and OEB, are looking at Centers of Excellence approach for musculoskeletal, and that's potentially going to end up with a select number of hospitals or ASCs that do certain services. So there are winners and losers in that for that kind of a strategy, and I'm just wondering how a committee like ours doesn't have conflicts of interest when evaluating some things that are brought to it under these considerations.
Yeah, that's a good example. I don't know that I have an answer for that other than we probably have to try it out and have that dialogue, knowing that we have people on this commission board that represent, you know, all sorts of stakeholders. I'd like to think we could have a full dialogue about that and endorse strategies that we know will have a meaningful impact on total cost of care. But you raise a good point. You know, Jeremy or Sarah or Michael, have you guys seen this play out in other markets where there might be some conflict on the board that is responsible for sort of approving these ideas?
Well, I do have a thought, which is, I think this is part of our thought of having this really be an ongoing committee of the Health Policy Board, which the Policy Board has a limitation that it has to be a minority number of folks from industry. And so I think if the committee is making recommendations up to the board, it's sort of informed from industry perspectives, but there's a little bit of some arm's length as well as the board's considering what strategies it may recommend to the legislature.
And I would also add maybe to Craig's other point, I think we're not at this point recommending a single path where strategies go. I think it's going to be very strategy dependent. So the value-based payment compact strategy was one path. Another path might be back to the policy board. It might be to the legislature. I don't think we're trying to say there's one set process and ask you to agree on that. I think we're saying, depending on what the strategy is and how it would need to be implemented, there are multiple ways it could move forward. And some of that might be more subject to the conflict of interest conversation. Some of it might not be. There might be other checks and balances along that path. And some of it might be more just industry taking direct action.
Yeah, I have a couple other thoughts, Craig. First, I want to clarify in response to your question. No, not everything would go to the legislature, but there might be certain recommendations that you have that would make sense to go there. Okay, but I think we were trying to indicate here that there are multiple pathways in terms of where recommendations would follow. And then two, I'll share with you that in Rhode Island, they've dealt with this a little bit. State government there has said there are certain strategies that we as state government need to carry and that don't make sense to go through a stakeholder body, which actually looks a lot like this one in terms of configuration. But there are other ones that make a lot of sense to go through a multi-stakeholder body like this one. And so, you know, to that end, there may be times when state agencies think we need to take some action that only we can take, and it wouldn't be appropriate for us to process them.
That makes sense. Thank you.
Yeah.
You know, I do feel though, Craig, that this is a committee that has the right stakeholders around the table to have a rich dialogue about those very challenging strategies. I mean, another one I thought of as we were talking is we may find after we look at a year or two of data, we probably know this now, that imaging that's done in freestanding non-hospital environments produce a lower price point, maybe because all they serve is the commercial market and they don't do much Medicaid. We may decide as a committee that we ought to change our benefit designs to encourage everybody to get their elective imaging at an independent non-hospital setting. But if we did that, that would have an impact on hospital financials. And, you know, is it fair to leave the hospitals with all the Medicaid and no Medicare? So, I mean, those are the kinds of gives and takes that I can envision this committee having. And I think we have some very thoughtful people on this in this group who could reconcile those competing interests and values, actually. So that's what I would envision would be coming in front of us as we think about this. I don't know if that's a good example.
I think that's helpful, Jack. I agree with you. I think some things make a lot of sense to come to the committee, but it's good to hear there's a different path potentially for other recommendations.
And Jack, I would just add just a reminder that, you know, part of this program includes an annual report from the Health Policy Board to the legislature. So I would imagine that this committee's deliberations and things they're considering would be part of that annual report. Some things might be recommendations for legislation. Other things might just be recommendations for industry to take action on or other ways to implement it.
Yeah. Yeah, that's great. Jessica, your hand is up, but is it up because you have a new thought, or are you still up?
No, sorry, I'm still up.
Okay.
And did I see Catherine
Yeah.
hand up briefly?
That should have been taken down a while ago.
Okay.
About
Not to
that.
worry.
I can't get it to lower. Sorry about that.
Okay, very good. This is a good dialogue. Are there other comments before we kind of continue on here?
I think that I just want to make sure that some of the comments that have been made, or the pieces of the comments have been made, get captured in the meeting notes for this. I think the meeting notes they're fine, but I think these key points around the discussion, I think, need to be in writing as these strategies develop, to guide the future process about how we're measuring these strategies.
Mm-hmm.
Lisa, is there anything that you wanted to include in that 3-page document? Because I hear your feedback as primarily being about how the criteria are applied.
Yes.
Right. So I mean, for example, you're making sure that we don't let the perfect be the enemy of the good, is really interpretation of how to apply the substantive impact. I just want to make sure that we're responsive to you, and so I want to ask, are there modifications to that document that you'd like to see made?
I mean, I guess you could outline some of these items in the purpose or in a summary at the end. I think you get at the end of the document, you give sort of the outline of the example of how the process would work. You could outline a sort of summary at the end, or update it into the purpose.
Okay.
And then to Craig's point, having a clarity about not all strategies have to come through this. That there are multiple paths for multiple different types of strategies.
Okay, great, thank you.
Okay, Michael, do we need to keep moving here?
So it sounds to me like with those little modifications, people are comfortable both with the criteria and the process. The only question I have for you, Jack, is whether you want to take on either of the two topics that John asked that we discuss.
Yeah, I would. Yeah.
Okay.
You want to address those, or?
So I think I can respond to the first one,
okay.
at least. And that was a reflection on Massachusetts and Rhode Island. So for those of you not aware, Massachusetts and Rhode Island, and actually I'll add in Delaware, although I'm suspect about Delaware's calculations, they all reported that they exceeded their cost growth target for 2019. And I'm going to focus on Rhode Island and Massachusetts because I interpret the results a little bit differently. Rhode Island finalized their 2019 cost growth target in December of 2018. So there was essentially no advance notice about their cost growth target. Very different than what's happening right now in Oregon, where we've already heard that contractual conversations are referencing the cost growth target. There was no time to do that in Rhode Island. So I'm not surprised they exceeded the cost growth target for the first year. They have a target of 3.9% and they came in at 4.1. And commercial and Medicaid were both over. I think it will be more interesting for Rhode Island to see what happens in subsequent years, where there was more awareness of and probably likeliness of application of the target in negotiations. The Massachusetts finding is different, and I would say more concerning. Massachusetts has had their cost growth target in place since 2012 legislation. And up until the last couple of years, they were performing really well relative to it, but they exceeded it by quite a bit for 2019. That's suggestive to me that that what they were doing isn't working as well. Oh, Megan asked me to clarify that apparently I said the target in Rhode Island was 3.9%, it was 3.2%, and they came in at 4.1. Sorry if I misspoke. The Massachusetts result is more concerning, and I know from conversations in Massachusetts that they are now talking about, do we need to do something more? Including, do there need to be stronger consequences for not meeting the cost growth target? And that might be necessary. I will note that Massachusetts, they were first. They are doing some things that are different than what you all are doing. First, their cost growth target was established in statute in ways that are very limiting to them. That's one. Two, they do not have a body like this implementation committee that brings together stakeholders with multiple perspectives. And so they established the cost growth target, and the state puts out fantastic analyses of what's driving healthcare spending, but there's no collaborative effort to then try to move change to address the cost growth target. I think that you're having such a process is a big advantage and increases the likelihood that you're going to have an impact. Now that's a little speculative. I don't want to acknowledge that, but I do think that there are some differences. And of course, the new legislation that just passed creates much stronger consequences than what Massachusetts has.
Michael, this is helpful. Can you tell us when the news broke that Massachusetts did not hit the 2019 target by a margin? I don't know what it was, doesn't really matter, I guess. But how did the press cover that? Was there a lot of dialogue about that? Did Charlie Baker, who was a health plan guy, have a press conference to, kind of express his disappointment? How did the public respond to all this? Or is it ongoing?
Yeah, I would say it's ongoing. There was, some one-time prominent coverage that said we blew through it, and this suggests that maybe there need to be strategic changes. The governor did not address it, but with all that's going on with COVID and reopening the economy, that's where he's focused right now.
I get it. That makes sense. Yeah. Okay. But you're saying this could lead Massachusetts health leadership to consider some new tools and ways to address it in a more direct way.
Yeah, I think so. I mean, like Oregon, Massachusetts, when it comes to health policy, has a pretty activist legislature. There are a lot of states that do not, but Massachusetts does. Yeah. And so both the legislature and the administration might be seeking new tools probably next legislative session, because the news came out a little too late for this legislative session. Okay. Again, I'm speculating, but.
And my last question, was there any, were there 2 or 3 factors that were identified as to the reasons that Massachusetts didn't hit it? Were there some, leading indicators? Did unit prices go up too fast? Was it utilization? Any thoughts on that?
So Megan, help me here. I recall that it was hospital spending that was driving it, but Megan, do you recall any of the other details?
Just curious.
No, I think it's hospital outpatient spending and pharmacy spending.
Pharmacy spending is, yeah. Okay. No surprise. All right. Well, interesting. John, any reaction or comments here?
Great context. Really appreciate it. Thank you.
Good. Okay. So Sarah, Michael, do we need an action here? You're just kind of surfacing this as kind of a first bounce. We're not looking to take an action here on how we consider new cost mitigation strategies. This is just to kind of get the committee comfortable with some ideas that we'll settle on later.
Well, no, actually, the next slide poses the question. We would actually like the implementation committee to consider adoption.
Okay.
But this is our second pass through because we shared some additional initial language in March. And so I think we are presenting both criteria and processes because we're anticipating in the coming months, there will be some strategies that will begin to bubble up. And we'd like you to have some identified criteria and processes when that happens.
Yeah, very good. Okay. So Craig, it looks like you have a question.
Yeah, just one more point of clarification on the strategy document is I don't have a good sense of time frame, meaning I see something about timely implementation, but I'm trying to figure out if some strategies could take 10 years to have an impact, as an example, maybe 20. Maybe those are really good strategies, but is there anything that help clarify how we prioritize around time frame, or is that even a factor to consider?
So can I turn around, Craig, and ask you the question, what you would suggest in terms of time frame, what you think?
I think we should consider it at all, but we have to be practical, I suppose, about how much we can take on. But I think probably what will have the biggest impact are these longer term upstream strategies. That's my sense.
So you would recommend allowing for inclusion of strategies that have a longer time frame to implement and have impact?
I would, yes.
Lisa?
Yeah, I feel like I'd like to differentiate here, Craig, Tim, and what you said, because there's implementation of a strategy and then there's seeing the impact of a strategy. And those are two separate items for me. So a strategy might take, 10 years to implement, but may not, the impact may be lower, but a strategy may take 10 years to implement, but the impact of that strategy you might not see for 20 years. And it seems worth it to me to focus on the implementation versus that having a shorter time frame on the implementation and focusing on the implementation timeline, but acknowledging the impact timeline. Does that make sense?
Yeah, that does. That's really helpful to make that distinction. I just wasn't clear on both implementation and impact, if there was a time frame contemplated in these strategies.
Yeah, there's not one that's explicit here right now. So guidance that you all would want to provide.
I think the guidance, to Craig's point, is an implementation that could take a long time, could have major impacts. And so it's worth not, again, this whole perfect, being the enemy of the good, like chasing and not limiting ourselves to chasing quick wins. I think could become very detrimental when you head into a sort of a slash and burn sort of mentality when you're trying to chase these quick wins, as opposed to knowing you might implement something that takes 10 years and then you'll see the impact, not in my lifetime. That's okay.
So Jack, I wonder if we should get a read on whether the full committee is comfortable with giving flexibility to consider strategies that will have a longer time frame and not require a short ROI.
Yeah.
So to speak.
Yeah. Do people have thoughts about that? I personally think that's fine. I don't have issues with that. But other thoughts on this for people around the table? Comments? Yes, Mary Beth, please. Thank you.
Yeah, I would just say that I think that it's part of the analysis as a whole. It's not the be all end all, but it's something to consider when we're considering each strategy. And the time frame for each strategy is going to be different. So the time frame for the value-based payment compact is going to be different than the next one that we consider. And so it should just be part of the holistic view that we take when we are looking at each strategy and evaluating whether we want to implement it or not.
Yeah, good. Thank you. Other comments or thoughts? are people comfortable with the process that's been developed here in terms of how we surface and initially score and then have dialogue? I mean, the good news is almost all of this work will come back to this committee for a full, thoughtful vetting. And that's important, I think. Other comments? Are we ready to make a motion on this and get approval on this framework for considering and adopting new tactics to control total cost of care? Any comments? Any thoughts?
Jack, this is Angela. Just real quickly, if a payer wants to do something outside of the considerations, is that allowed? I'm assuming that it is. I mean, different payers are going to have different strategies potentially, but there'll be a foundation of baseline.
Yeah, I can't imagine that this would hamper any individual payer or provider from, searching for a way to lower total cost of care. We're not gonna be the place that reviews all ideas and tactics. My hope would be if payers come up with a good idea that seems to be working, it's reflected in the data, and they would come and share that in some way so we could all learn from it. But I understand in competitive environments that might be a challenge.
I just wanted to affirm it.
Yeah, I think that's right.
Thank you.
Good question. Other concerns or thoughts? Okay, well, hearing none, can I get a motion to approve this framework for evaluating and potentially adopting new cost mitigation strategies?
I'll make a motion to approve the framework and the process with the addition of the conversation outlined in the proposal.
Yeah. Okay. We have a motion from Felisa. We have a second?
Okay.
There's a second. All right. Do we have any further dialogue?
No.
I don't see any. So I think unless there's any opposition, I think we're in favor consensus, and we have a method. So thank you, Michael and Megan and Sarah, for this. Great. All right. And we also ended a bit early. So Sarah, help me out here. I'm trying to go between screens. This is, we were going to take a break after this section, right?
Yeah, we're a little bit ahead of schedule. So do we want to go back to John's second question and talk about the messaging a little bit before we take a break?
Sure. Can you resurface that one again?
Me or John?
John.
Yeah, I think this is for people who are working with the health system and they see the press on this and they want to know what do I think about this? Do we want to have some bullet points or standard response, or how do we respond in a way that's going to be most effective and helpful to them?
Yeah, that's great. Well, Jeremy, I might turn to you on this. I mean, does OHA have a standard set of I don't know, slides or something? What would be your guidance here so nobody on this committee goes off half-baked like perhaps I have once or twice and gets us in hot water?
Jack, I always like to see where you go half-baked because I usually get a call right afterwards. So
yeah,
just fun to see. I think we're I think I kind of turn back to the group, and we're happy to put material. We obviously have lots of materials. We've talked about needing to do some broad education and outreach this year as well, and need to come back to that generally. We've been trying to get sort of past session, but that's certainly going to be a big piece of our work this year. I'm happy to have some kind of a packet together if that's useful. So I guess maybe it would just be helpful to hear from the rest of the group. How can we support your conversations? Is it a set of materials? Is it connecting them with Sarah and I to do a rundown, or what would be most helpful?
Yeah, if can I elaborate on that? There's probably a lot of things to touch on, but I think sort of two things that I see, and I think some of this comes out of conversation that you and I have had, Jeremy. So one is I think they're starting to see this, but my impression is that there's movement on value-based payment in kind of the Medicare and Medicaid settings because those contracts are coming out there. There are those value-based payments that are happening on the commercial side, but also sort of momentum to continue to pursue revenue growth as a strategy. And I think that sort of feels in conflict with some of the benchmark. And so how you reconcile those and sort of what does that look like? So, these are organizations that have spent their whole life thinking about revenue growth, and maybe that's needs to change. What does that look like? I think that's number one. And number two is I have a slight sense that some of this is being socialized and talked about within hospitals, which are smaller number of large groups, but maybe on the once you move down to smaller organizations or positions, it might not be known. And so what that conversation, how that gets socialized there and what that conversation looks like, I think that would be another piece of the puzzle here. But those are the things on my mind, is just sort of how do you change the conversation around revenue growth, which is how a lot of these groups think.
Jeremy, this is Jen. I think having some type of standardized education packet that all of us could use in conversations with our medical staff, with our provider groups, with our business partners, I think that would be nice. We've internally made one at St. Charles that I sort of take around with me and present to people, but having maybe a standard one that we could all rely on would be effective, and really then we become an extension of the communication strategy that OHA has.
Mm-hmm. I would echo. I'm sorry, Jack. I would echo that. I think having some talking points would be useful. There's a lot of confusion that I hear regularly just between 889 and the voluntary value-based compact, and just being able to have some standard ways that committee members answer that, I think would be useful.
Yeah, I think there's consensus. I know I have historically turned to Sarah for, a slide deck that has been very consistent and very helpful. So I think that's a great thought. Do people, other comments on this?
I think we had planned on bringing back what we had previously talked about a provider outreach strategy to you all for discussion in July. I think we could broaden that and have a conversation in July about a comms strategy and some materials. I do think in the short term, we do have a variety of canned slide decks and talking points that we can maybe package and push out. And I think on a one-on-one basis, if you have a meeting that you're going into, let us know if there's anything we can help you prep with. We've already done that for some of you. And Jen, I don't know if your internal slide deck is something that is shareable or confidential, but that might be a nice example for to see how some of the message is being translated.
Yeah, mine is mostly cut and paste from things from the committee, right? Just kind of assembling it and then a little call to action about what we're doing internally. But for example, I'm presenting to the Mosaic leadership team. Well, I'm not part of Mosaic, but I'm presenting to their leadership team later this week. So I think the word is getting out there. So the sooner that we can have sort of a nimble deck that we could use would be great.
I think the passage of the accountability legislation is going to even promote this more, because the reality of performance improvement plans and potential financial penalties is going to raise, the angst a bit. So Sarah, maybe could I recommend that maybe you take the lead with Jeremy in putting together a 10 to 12 page slide deck. I don't think we want it too long, but you decide. That maybe we could circulate in the next week or two. And then in our July meeting, we could have dialogue about it and maybe close in on something that everybody felt like was a starting point that they were comfortable with. Does that make sense?
Yes, with a small caveat. I think there are so many different angles to this conversation that many of you have been reflecting that I would really be nervous about being able to do this in 10 slides.
Yeah. Okay,
so
fair
maybe
enough.
We'll put together sort of a comprehensive packet and people can just pull from it as needed. We also have some Q&A slides and some talking points that we can package up. And I think, again, we're happy to work with you directly if you have specific conversations that you're going into and want to prep or address something that's a little more tailored for your conversation. But I think we can definitely commit to getting something out that you can all pull from.
That's great.
I would ask, Jack, that we don't make this something that the committee needs to officially approve. I think this is just to help with the
Yeah,
message. This isn't.
I think that's fine. I think that's great. Does that, is there a nodding of heads that this would be helpful and generally acceptable? Yeah.
We'll put it on the agenda item for July. I mean, we'll get the slide deck done and materials done. And if for some reason, even whatever we put together as sort of stock doesn't work for a certain audience, feel free to let us know. We can, Sarah has made about 100 versions of this for me over the last year. So we have a lot around. But we can put a broader agenda item on July around kind of what our overall outreach and education strategy will look like for the rest of the year. I think both to make sure it seems like we're hitting the mark, but also to think about how we could tap into you all to some degree as sort of ambassadors for this work and help us carry some message.
Yeah, I would just say from experience that for those of you that are asked and you need some help, Sarah has been wonderful to, turns things around and does beautiful slide decks. And I have benefited from those, and I know you will too. So
can I just say how exciting this is? Like I feel like the fact that we're having this conversation already, people are talking about implementation, they want to know how to incorporate it. I know that that's a lot of work for John, and I appreciate all the work that he's going to do around it, and other folks, but I just want to appreciate people who are already out there thinking about this, implementing it, starting to get it done, especially since we just heard Michael say Rhode Island didn't even kick theirs off yet. So like, we're talking about contracts that are going to start this summer. And so all of the work that we've put into place over the last year, it's just awesome.
yeah, and I thank you for saying that, Felisa. And I do think it's a tribute to the leadership in the provider and payer worlds in our state, that there's people are not fighting this because in principle, there's a belief that this is the right thing to do. So I want to extend my heartfelt thanks and acknowledgement to provider and payer leadership that are in the trenches right now trying to get this done. Thank you very much. Okay, so John, does that answer your concerns there about a communication piece? Does that work for you?
John had to drop off, but I will follow up with him to confirm.
All right, very good. Yeah, what else, Sarah?
Jack, sorry, before we break, do we want to circle back to Catherine's question about the charter?
Right. Right. Do we have some new, did you between now and then, did we do something in the language of the charter that you want to share, or what remind me here?
I have not edited anything, but Catherine, to the question you raised earlier, do you feel like the process conversation we had about reviewing and what happens to strategies and where they go, do you feel like that's addressed, or are there other edits that you'd like to see to the charter still?
Right.
I think that as long as it ties back to the documents that we talked about in the charter, that would be just fine. Just seeing that link. And so I'm comfortable with it. I just didn't understand it enough. So when you looked at the red line, wanted to make sure before voting on it. I'm fine with it as it is.
Good. Okay. Thank you, Catherine. Okay. So I think why don't we do this? We're a little bit ahead of schedule, and I have 9:51, 9:52-ish on my computer screen. So why don't we take a little extra time and reconvene at 10:05?
So Jack,
sorry.
So does the group want to go ahead and approve the charter? I just wanted to make sure that loop was closed.
Oh, yes, I'm sorry. Sarah, were you looking to get an approval on the charter now?
That would be great.
Okay. All right. So with the caveats that we have heard.
That we approve the charter.
Okay. And can I get a second on that?
Second
from Bill. Okay. Any additional thoughts or concerns or dialogue? Okay. Hearing none, I think we have an approval of our charter. So thank you for that. Michelle, was that you who reminded us? I appreciate that. Not sure who that was. Okay.
It was me.
Oh, it was Megan. Thank you, Megan. Sorry.
No problem.
All right. So let's do this. Let's take a break. We've been at it a couple hours, and we will reconvene at 10:05. Give you a little extra time. Okay. Good.
But we'll do a check-in once you reconvene us all.
Okay. So this is the part of the agenda where we entertain any comments from anybody who might be listening in. Is there anyone on this call or in the universe, for that matter, that would like to make a public comment about what you've heard or haven't heard so far?
Yeah, this is David Ladwig. I would like to put in my 5 minutes worth or so.
Okay, and tell me your first name again, sir.
Yeah, David.
Okay, David.
I've been a lurker at most of your meetings since the beginning.
Right.
Yeah, I got out of graduate school in 1987 and retired in 2018. 19 of those years I spent working with insurance companies, including Harvard Pilgrim Healthcare, which Charlie Baker bailed out of bankruptcy. The last 9 years that I worked with Anthem, Blue Cross Blue Shield, predominantly with California. But Anthem had a process for cost of care. And, you know, it was a pretty solid, because they would look at year over year change in a number of categories and look at that systematically. And they had a large number of analysts and consultants and above working on that. The problem with insurance companies is they have a limited set of tools to do anything with those cost of care differentials. And it also baked in, you know, cost differences that were there from the beginning. For example, different hospitals charging 30 or 40 or 50% difference in amounts. Just as an aside, Dartmouth Hitchcock Medical Center in New Hampshire, and I have no reason to doubt the credibility of this, they actually were able to survive on Medicare reimbursement. And they used money they got above that for outreach and improving. Besides the 19 years I worked with 3 different insurers, I also worked for 2 years at Harvard University Health Services, and they had the perfect model for being able to integrate providers and payers, you know, for change, because they were a self-insured provider. In fact, their electronic health system was the primary source of data, and we had to do a Joint Commission accreditation. And some of you are probably familiar with the ORIX measures for JAGO. And we did one on diabetes care, because we had the electronic health records as our predominant source of data. I've read, and I also have no reason to disbelieve this, that the biggest drivers of healthcare are pharmacy, of healthcare costs, medical devices, or that would include medical devices, you know, different technologies or different protocols for care, and integrating delivery systems. And you could see this big time in California, where one of the big hospital systems would buy up independent practices, and all of a sudden the cost of treating something would go up by, you know, measurable impact, certainly on the region, but also for the whole state. And I'm glad to see, I've been tracking the HB 2081 and putting teeth on the processes and the recommendations of this group. And I'm interested to see, you know, I've read it over quite a few times, of all the providers and payers being required to submit data. And I'm really interested to see if that will include the different providers of pharmacy, because obviously that's one of the biggest drivers. And I doubt that it will, because there's some other legislation pending, you know, to try to just look into the cost drivers for pharmacy costs in the state of Oregon. And as you can expect, pharma is already spending probably more money than the state of Oregon would ever spend to try to implement it, to fight that. But I guess that's my main things. So this group, with the meat of 281 or 2081, in trying to integrate payers and providers, I think have a better opportunity to really change the costs. That's my spiel.
All right. Well, thank you very much for sharing your thoughts. We appreciate it, sir. Thank you. And thank you for listening in. Do we have anybody else who would like to make comment?
No.
Sarah, do you see anybody? No, I don't think we have anybody else, right? Okay, well, all righty. So with that, we will end our public comment section of the agenda, and I'm going to turn it over to Sarah and Rebecca, who are going to give us some of the highlights of this was a 2019 survey, I believe, and take us through some of the highlights and see if there is some dialogue we can enter into and lessons learned here, okay? So Sarah, it's all yours.
Thanks, Jack. I'm going to walk through the slides, but I want to.
Sarah, we can't hear you.
No. Can you hear me now?
Yeah, that's better.
Okay, sorry. I'm going to walk us through the slides and cover some data highlights and provide an introduction to the Oregon Health Insurance Survey and just a little context for why we're bringing this to you today. But I also wanted to quickly introduce Rebecca Gould, who's joining us. She is the lead analyst in the Office of Health Analytics for the Oregon Health Insurance Survey. So anything that I say wrong, she's going to correct me, and any technical questions are going to go to her. So thanks for joining us, Rebecca.
Absolutely. Hello, everyone.
Welcome, Rebecca. Thank you.
All right. So Michelle, next slide, please. So as we've been telling you for a year now, we intend to regularly bring data forward to the committee for consideration. This is going to help with monitoring. It will provide additional context and helping understand the broader healthcare cost landscape. This will include work from the data use strategy with the cost drivers and the cost impacts. It will also include the framework for monitoring and looking at those negative impacts as well. And as we were just talking about earlier in the meeting, these conversations and presenting this data will be opportunities to consider potential strategies to address what we're seeing, whether that's drivers or negative impacts. We will have a chance to test out those criteria you just talked about earlier. So we thought that today's presentation of the Oregon Health Insurance Survey data could be a light intro to that process. This isn't quite as heavy as some of the data use strategy analysis will be, but we thought it would be really helpful to bring forward some data on consumer cost impacts. So this data has not been published yet. It will be coming out later this summer. So we're giving you a little bit of a preview for that. But we really wanted to just sort of spark your conversation and potentially after we present the data, bring you back to some of those strategy conversations. So you may not identify strategies today. I'm not really asking you to specifically identify strategies, but just recognizing that as you consider this data, some strategies might bubble up or you might have some ideas. We also wanted to make sure you had some space to ask questions about the data and identify other questions that might be of interest related to this data. Some of that data might already be available and will be part of what's being published this summer. Some of it might be additional direction that we can take back to the team and continue doing some analysis on. So I'm going to start with a quick overview of what the Oregon Health Insurance Survey is. This is a survey that we field every other year in the odd years. It's been fielded since 2011. There were some changes with methodology and vendor in 2017. And then the 2021 survey is currently in the field. So the 2019 data is still the most current that we have available. The 2021 data is coming in now. This is a random digit dial survey. It includes cell phones and landlines, and it's fielded in English and Spanish. And Rebecca, correct me if I'm wrong, the 2019 survey was fielded between March and August of 2019.
Early April, yes.
Early April. Okay. Thank you.
Yep.
Okay, next slide. So the target population for the survey are all people in households living in Oregon, and the survey collects data at the individual, family, and household levels. So there are different ways to group the information depending on the questions and how we are thinking about the respondents. Next. And then the Oregon Health Insurance Survey has a lot of different topics that it covers. So a lot of the questions are about insurance status. So whether or not a person is covered, what type of coverage they have, if they're uninsured, why, if they changed coverage, was there a gap in that coverage? How long was there a gap? Why did they change insurance? We also ask questions about eligibility. So if people are uninsured, are they eligible for Medicaid? Are they eligible for the exchange and subsidies? Do they know that they can access those resources? There are also questions about health status, about mental health, physical health, and dental care, demographics, underinsurance, access, utilization, and then what we're going to focus on today, which is cost. There's an entire set of cost questions, and we're going to dive into two of the topics in the cost bucket. One is about delaying care. So did respondents delay or defer care because of the cost of care? And then difficulty paying medical bills. So this is looking at medical bills that have already been accrued and what that looks like as consumers try to pay or try to balance the medical bill with other bills or cost priorities that they have. Next slide, please. So the Oregon Health Insurance Survey data is available online. There are interactive dashboards that you can go to click through and explore the data yourself. There are also a number of summary briefs that are published on the different topics. So the 2019 insurance coverage data and data about the uninsured population are available. The cost and affordability questions that we'll be talking about will be available later this summer. There are 26 different variables of cost, and there are 16 different demographic variables. So lots of different ways to view those cost questions. We're going to look at just a snapshot, just a couple of those top of those variables and lifted up, but there's going to be a lot more available. Okay, Rebecca, did I miss anything critical about the survey before we start talking about the data?
No, one question that does come up a lot that I might just mention is we do not ask about citizenship status in the Oregon Health Insurance Survey. So that's one question that comes up frequently. There is a possibility because it's a cell phone sample. If people have an active Oregon phone number, they can be in the sample, but we do not ask citizenship. We have a few different ways we can replicate or have a little more conservative. We have a question on if they were born in the United States, but not if current citizenship. So if you have a question about that, we have some alternative ways we can substitute, but we don't have citizenship if that's a question that some people might have.
Thanks. Are there any questions about the survey, the fielding, before we get into the data? Nope. Okay. Let's go ahead then. We're going to start looking at the delay in care because of cost variables next. And top line finding here for 2019 is that 15.7% of Oregonians reported that they delayed care because of cost in 2019. And obviously 2019, this is all pre-COVID. And so we're going to be looking very closely at the 2021 survey to see how this is changing and which direction this is changing in, but 15.7% delayed care because of cost in 2019. But there's a lot of differences once we start looking at some of those demographic variables. So on the next slide, younger adults, those ages 19 to 34, were more likely to delay care because of cost than other age groups. Maybe not surprising. Next, we also know that uninsured Oregonians were more likely to report delaying care because of costs than those folks with other insurance types. And the data that we're looking at here are for people who had this type of insurance coverage for all of the past 12 months. So some people do change coverage within a 12-month period, but we're only looking at those who consistently had one type of coverage for the full year. Also want to point out here, the Oregon Health Plan or Medicaid, 15% of respondents who had Medicaid for the last year reported they were delaying care because of costs. There is no cost sharing with the Oregon Health Plan. Oregon Health Plan members often cite the cost of care, but we think this is likely a misunderstanding about what's covered or whether or not services are available. So disappointing to see that here perhaps, but just clarifying that there is no cost sharing for Oregon Health Plan. And then next, looking at those that reported they delayed care due to cost by race and ethnicity. So Oregonian respondents who reported that they had another race or those who were Native Hawaiian or Pacific Islander were most likely to report delaying care due to cost. And there's almost 3 times as many of those respondents than Asian Oregonians or Black or African American Oregonians reporting delaying care because of cost. So pretty significant disparities here across the state. And then next, looking at what type of care people were most likely to report delaying, dental care was the most likely. And here, this was not limited to just one option. Respondents could check multiple. If they delayed multiple types of care, they could indicate that. So not mutually exclusive. Rebecca, any other nuance to add to the delaying care because of cost?
I might just add that the first number we saw at the beginning was over 15, nearly 16%. And part of the reason that number is so much higher here is we combine people that said any of these types. So that's why the number is higher than these individual types of care. They're all combined into one variable for the overall.
Thank you. Any questions or comments about the delaying care due to cost? Okay, then let's go to the second variable, which is difficulty paying medical bills. So again, next slide, starting with the top line finding, 7.7% of Oregonians reported that they were unable to pay medical bills in the past year. And again, once we start breaking that down by some of the demographic variables, we'll see quite a bit of nuance there. So next slide. Again, uninsured Oregonians were most likely to report inability to pay medical bills in the past year, just over 15%. But really closely behind that is those folks who have individual coverage in the commercial insurance space. Again, we're looking at folks who had the same type of insurance for all 12 months here. We know that 10% of Oregonians reported trouble paying off medical bills over time. And next, just over 10% of Oregonians report using up all or most of their savings because of medical bills. Next slide. Yep, thank you. Jessica?
Yeah, question. Is there any way to tie this data to any kind of income data at all?
Thanks for your question. This is a survey that we have, it's anonymous, so there's not a direct link variable in this data set to any administrative data. We do have the option for some respondents that said we could follow up with them for further questions. So I don't know that we can directly link, but we could possibly get further information on certain groups of people.
I think if we do this the next time, it might be really helpful to understand what income bracket, people are in and how they're responding.
Well, we do have income data. So if we wanted to look at these variables by income levels, particularly FPL, that's a variable we have, and it will be in the online tool. And then if it'll be just single variable. So if you wanted to layer like coverage status with FPL, that would be an additional analysis, but we can run any of those types of analyses you're interested in.
Yeah, I think that would be really helpful for me at least.
Yeah, if you'd like to let Sarah know specifically what you're interested in, we can get that for you.
Thank you.
Yeah.
Okay, well, let's look at just a couple more data points around those who report using up their savings on medical bills. So again, we see that uninsured Oregonians were most likely to report using up their savings, 19%, followed by Oregon Health Plan, Medicaid at 11%, and then individual and group commercial market at 8.5%. And then again, looking at this variable by race and ethnicity, we see that Native Hawaiian or Pacific Islander Oregonians were 3 times as likely to report using up their savings on medical bills compared to the other populations.
So Sarah, this is Scott. I was just curious, were there any follow-up questions in the survey about why they were trying to delay care in some of these scattered, well, I don't know, in all of them, were there follow-ups? It was just a blanket question on delaying care.
I'll answer that for you, Scott. There are follow-up questions. We ask how much they have that they're paying off. We ask what type of care that led to the bills that they're paying off. And I think there's another one about, there's questions about how, if it's affecting other areas of their finances, like if they're not being able to pay rent or buy food or things like that because of their medical bills.
Thank you.
Yeah, and all of that data will be in the interactive tool later this summer.
And Rebecca, this is Jack. If I could ask another question, you know, I was actually surprised that it was only 10% of people who claimed to have concerns about paying their medical bills. I would have expected more. Is this? Do we know how these data for 19 compare to previous years? Is that kind of been the number that we've been hovering at? Because with all the high deductible plans in the market, in the individual market, in the small group market, and of course with high unit prices, I just would have expected, you know, more people to be impacted.
Yeah, I have that data right in front of me. Let me pull it up. So in 2019, again, it was about 10%. It was much higher before the ACA expansion in 2014. We were looking between 26 and 31% of people that delayed care. So there's a big shift. Okay.
Of course, the ACA has been around for about 10 years. So that's right. Yeah. So.
Right. Well, we have data in 2011 and 2013 before it went into effect. So we can look back.
Exactly. Yeah.
Right. Yeah. And I feel like I said it a few times, but all of those years of data will be in the interactive tool. So we can go back and look at all of these variables that are available every year. Some are not, but many of them are.
Great. Thank you.
Yeah.
Are there any other questions about the data that we presented or data that we didn't present, but that you'd be curious about before we open it up for broader discussion? Okay, I think we'll be here if more technical questions come up, but Jack and Kevin, we maybe had some facilitation questions that you were going to bring up for the group.
Yeah. Kevin, you want to, our co-chair, Kevin, you want to lead this dialogue? Are you still with us?
I am here and ready to go.
All right.
I would just be thinking of, you know, by looking at this data initially, what do we think that this data might be telling us? How could we, as an implementation committee, look at this data? Are there trends that we might be able to see in our efforts to be a more robust implementation committee looking at costs? So first question, just what do we think this data is trying to tell us? Thoughts?
Jessica, looks like you had your hand up.
I think we need better dental coverage. I know that I see that in my own business. It's very challenging to find commercial coverage that'll cover more than 50% of cost for dental care. And it's a really big issue, and it's an indicator of overall health, right? If someone can afford to take care of their teeth, they typically will have better outcomes much further down the line.
Yeah.
One of the interesting things I would like to see in the future, the questions that were related to access. Will there be a change post-COVID as we continue doing these surveys now that telemedicine, telehealth visits have become more prominent? So that's more of a comment for future use rather than a question.
Yeah.
Can jump in. Sorry, we in 2017 on the OHIS, we did ask a couple questions on telehealth services. They were not responded to very much at all in 2017. So we took them out in 2019, but we did add them back for the 2021 survey. So we'll have that data with a comparison point early in 2022.
Wonderful.
Yeah, I mean, on that score, and I, William, I know you've got your hand up, and I'll get to you. I was curious, Sarah, Rebecca, do we get a sense that people are blocked to get their primary care needs met as a result of cost? It would be hard to, it would be difficult to know if people are not getting to primary care, given that most benefit plans try to make that pretty easy. And there's so much value in patients having ongoing relationship with their primary care. Is that a concern that we have in this data?
I can tell you that it's one of the lowest types of care that is delayed because of cost.
Okay.
In 2019, it was 4% compared to about 10% overall. So it was much lower.
Good. Yeah, that's good to know. Good. Okay. William, it looks like your hand's up, but we can't see you. And now we can't even hear you. Are you there, William? Just his hand, just a fake hand is there in William's spot. William, if you have, oh, there he is. Okay. But I think you might be frozen there, sir. Well, Sarah, am I the only one? Oh, here we go. I'm not sure we can get to William's question. William, hold tight, and we'll see if we can listen to you in a minute. Are there any other comments?
William, if you want to drop your question in the chat, I can read it for you.
And while we're waiting for that, another question just for the group, but was there anything in the data that was presented that surprised any of us? I for one, was surprised about the Medicaid rates of people stating that they had high medical costs. And Sarah, you had very well stated that there is no cost sharing for our Medicaid recipients, but I was still interested to see that higher percentage for some of the other questions. But was there anything else in the data that was surprising? Felisa, I see your hand up.
I think that when we talk about healthcare costs, sometimes we talk about the direct costs. So I will say that for our members who are very low income, when they talk about they can't afford to go to the doctor, it not is necessarily their copay, it's the other stuff that comes with going to the doctor. So if you're a Medicaid recipient and you have 2 days of work a week, and that's the only day that you can get in, taking that day off is a big cost for you. The public transportation or transportation to get to and from the facility is a cost to you. And so I think sometimes when people say, I can't afford to see a physician or I can't afford to go to the doctor, they're not necessarily just talking about their copay and their deductible. They're talking about the other cost, especially very low income people, where the cost of gas to and from is sort of combined in that. So I will say some of that could be in there as well, as not knowing that they don't have copays. I also think the other piece of that could also be that we only cover the prioritized list, and the prioritized list doesn't go down. very far, frankly, because we've had so many years of cuts. And so when your primary care, somebody recommends a service to you that you can't get because you're on Medicaid, then that becomes a barrier to you getting that service because you definitely don't have the money to get that service, whatever that may be. And those are serious things. I mean, at one point we thought we were going to cut off a collapsed lung off Medicaid coverage. That's real. So that's another component I feel like might be wrapped up in that overall cost. I think for me, what this data says is that cost just continues to be a barrier to access to healthcare in our state. And that is very real for people. And so I think, I think there are other components of the insurance survey that actually talk about costs and what people's overall concern of cost is. Because even if you can't afford it, it still is it's a big chunk of your income. So even if you can't afford it, it's still a problem in your life. $1,000 bill, a $2,000 bill is still a huge problem in, a $60,000 a year person's life. And so I think that's some of the stuff that is that's kind of missing a little bit from this conversation is how much cost is a problem, not just a barrier to access.
All really good, valid points, Felisa. Sarah?
And to follow up for William, William's comment is the Medicaid population is a surprise. Are we doing a good enough job of communicating their benefits to them so they're aware cost is not a barrier? So I think Felisa has sort of bundled that with Felisa's comments.
And I wanted to add too, from the CCO perspective, that many of our members may not be aware that there is, through non-emergent medical transport vendors, rides that are available to take Medicaid members to their doctor's appointments, et cetera, to their different appointments for radiological examinations. But maybe the CCOs need to be doing a better job of communicating that to the Medicaid members so that they're aware.
Greg?
Yeah, a couple of comments to Kevin, your question about anything that's surprising. The thing that surprised me most was the distinction between individual and group coverage. And in particular, it looks like individual coverage isn't as good as commercial group coverage. And that's surprised me a bit. I think there's probably good reasons for that. So it's worth looking at. I think one thing that comes to mind about the use of this data, maybe this could be added to our framework for monitoring too, not just quality, but just ensuring we're not having negative impacts of any of this cost containment work on what we're seeing in these surveys. On the dental, I think something to note there, and I agree, the coverage is not great for major services, but not all programs cover dental. Medicare, for example, doesn't have a dental benefit. And I think individuals in some groups don't, it's discretionary. So I think there's some coverage probably issues there. And that's why there's cost concerns. And then the last thing on the cost, I think Felisa's points are really good to keep in mind. But I also wonder, are the questions banded to the time frame? Meaning, could people on OHP have been concerned about costs or had financial impacts from medical bills in their lifetimes or some point in time, and it's not necessarily over the period that they're covered? It wasn't clear to me how that correlates.
I can answer that direct question. We did limit this data to people who had the same type of coverage for the entire previous year. So the look back is the past 12 months. So we limited to people who had the same coverage the whole year. So it should take care of that in this data.
Thanks.
One other thing I just wanted to add to on the Medicaid piece, we actually getting balanced bills from providers is one of the highest complaints that our ombuds folks deal with. Out-of-network providers, out-of-state providers, even though the members aren't on the hook for that, they still often will get a bill, and sometimes it'll go all the way to collections. and I assume probably even get collected on if folks don't know how to challenge it.
Jessica?
Yeah, a couple of things. I would, and I don't know if we have data on this at all, but one of the things I know is not covered in a lot of instances is physical therapy, especially for commercial insurance. And I know that even personally, I have definitely skipped out on physical therapy I probably should have had just due to the cost because it's not covered. Even things like eye therapy for kids that are challenged academically because of an issue with the eye-brain connection. So I'd be curious the next time this is done, if that could be maybe called out to see how much, because if you think about it, that is part of our preventative, should be part of our preventative care to avoid, other issues later on. And I don't think it's not something that typically comes up. The other is a comment that I have is around the telemedicine. I'm looking forward to seeing, if we can get some good data on that from 2020, because I think in a lot of ways that helps to mitigate the access issue, but then again causes a whole nother set of access issues having to do with broadband and internet access and things like that, and just sort of someone's ability to get online and speak with the doctor. So maybe let's try to collect more specific data on that once we have data for 2020.
Can I ask a question on this? Because I think this keeps coming up and it is nothing related to our work here. So I just need somebody to help me understand how telemedicine actually saves money. Because I don't, as far as I know, all of our folks still pay the same copay in a telemedicine visit as they do in an in-person visit, and you still have to pay the provider. So I get that you can have more appointments and they can be faster, but so if somebody has some data on that or studies on how telemedicine actually saves either out-of-pocket money or financials overall, can somebody send it to me?
Lisa, I don't know if I have data specifically, but it has been heard from some patients that utilize telemedicine that some of those other related healthcare costs, like missing work, et cetera, do not have to be undertaken, and there are some cost savings because of that.
I agree. I think that the main difference for telemedicine is just convenience and saving on travel. But from a direct cost like that, I haven't seen any measurable difference in what I'm charged when I have a televisit.
Lisa, it's an access issue. It allows people to have access. So some people who struggle to get to the doctor's office for transportation reasons like you referenced, this is a great way for them to get some access, as well as behavioral health. There's a broader accessibility to behavioral health providers through the telehealth, but it's not a cost savings per se, because especially now with parity laws being passed where you're actually paying the same for a telehealth visit as you are an in-person visit. So
yeah, I just want us to have real clarity about, I 100% support telemedicine, just like I 100% support electronic medical records, both of which are very, very critical items in overall care and quality of care. I just don't want us to go down a path where we're pitching things that as cost savings that I don't actually save costs. Right. I 100% am down for access, and I wish almost all physicians and providers generally did telemedicine via their phone and telephone, not even the face-to-face, just telephone calls, right? I like those good old days. They just don't save us costs.
You're right. They did historically pre-COVID when there was a cost differential, but no longer.
Brian, is that a hand up?
Yeah, just a reflection on page 37 that the different subgroups of, I'll say the BIPOC community, have different responses in terms of delaying care. It just leaves me with a question of why. I don't know if anybody has insight on that, but clearly I think Lisa was addressing it earlier. I mean, keeping track of, or somebody was, I apologize, I forgot who said it, but keeping track of this information around the equity piece is really critical. But even today, I'm just looking and going, I wonder, because that's a pretty significant difference in terms of percent of people reporting that they're delaying care depending on which subgroup of the BIPOC community they're representing. Be curious if anybody has insight in that, or if it's just, yeah, it's kind of an interesting.
It tracks with income, right? It tracks with income and lack of coverage. So if you look at every other data or survey, people of color make less money because of historical and systemic racism, and they have less full coverage healthcare because of historical and systematic racism of how they're employed. So it tracks with every other.
So at least 3 subgroups of BIPOC are reporting less delayed than whites. But then there's other people of color that are twice as much delaying versus, I'll say, another subgroup, right?
Yeah, but I think if you look at the top where the other category fits in.
Yeah.
So I think people like mixed race people, the other category, I bet you includes a mixture of more BIPOC people who may not identify as Black, who jump that number. And that number is pretty big when you look at the overall. So I also think Oregon has a lot of low income whites relative to other states. So we just have a lot of white people.
So your point of that income, that's come up a few times, how important the income information is important on this. Thank you.
Craig, did you have your hand up a minute ago?
Yeah, I think telemedicine, just real quick on the cost savings. This has come up elsewhere. Telemedicine, if we're done under fee for service, all else being equal, agree, that doesn't save anything, but I think it needs to be combined in a value-based care sort of arrangement. It could be beneficial both to the provider and to the people paying, and even the consumer from a cost sharing perspective. So I think it just needs to be thought about more broadly than just a replacement.
Becca or Sarah, I had an additional question about the pooling of questions coming from the commercial space, and whether there is thoughts or ways that you could drill down, asking the question of those that have high deductible health plans, and whether they are foregoing any of their preventive care due to costs or any other services due to costs. My sense is that would be a higher proportion, but I don't know if that was an option in the questionnaire.
Yes, we have deductible levels, and we have a flag in our data set for people that have a high deductible health plan. I can look in my data real quick, see if I can pull that up real quick, but it will be in our full dashboard.
Thank you. Any other questions from the group? Any other things we should be considering about what this data has shown us to give maybe greater potential for cost growth target programs for the future? I really like the discussion and the pointing out of the equity issues, very important.
I think from a staff perspective, we were thinking something similar to what I think Craig suggested, where these indicators, or potentially a couple of these indicators, could be incorporated into our ongoing monitoring for negative impacts. We think this is one of the potential data sources to look at consumer cost impacts, and we'd love to pull this in. So I saw some heads nodding when that came up earlier, so I think that's definitely one place to incorporate. But I think we're open if there are other suggestions or ways that we should be considering keeping this tied together with the cost growth target program moving forward.
Other comments? I'm not hearing anything else, Sarah. So thank you.
Up, Jack?
Yeah, I think we will. Rebecca, thank you very much for making yourself available. Yeah, I think we will wrap things up. Before we wrap up, does anybody have anything else to add to our dialogue this morning?
Can I ask a question? Sorry, Sarah. So this insurance survey is of individuals and it comes out every year. I thought that there was another one that is there an employer-based survey on healthcare coverage and insurance?
Yeah, they're not one that we do. There's a national survey called MIPS we've pulled a lot of data from, and it's a sample survey of employers as well.
I think that might be worth considering around. I find the insurance survey really fascinating and incredibly helpful. I think it's worth considering doing it for when I say, and not big payers, but businesses and other folks who provide commercially covered insurance, and what their thoughts are on their costs and access and et cetera.
Mm-hmm. Yeah, I think that's good. Is that something that we could get our hands on at some point and have a review of?
We can definitely share the existing MIPS data. There's the national and the state level data, and we can pull that through for you, no problem. I think what I heard Felisa say was, can we essentially field a survey that's specific to employers and those who purchase? Did I hear you correctly, Felisa?
Yeah, I think I thought that the NIPS survey, is it called that? Is it called MIPS?
MIPS with an M.
With an M. Okay, that's inappropriate. The MIPS survey, I thought we did locally. So I think it would be a good question if we did something similar locally, and I don't know if that's viable, or what the cost would be on that. And I don't know if Andrew is still on, or.
I'm not sure.
We can, I think, pretty easily summarize the data points that are in the MIPS survey, and it is Oregon data. I don't know. We obviously don't have access, I don't think, to the employers, which employers get surveyed, but we could pull, we've used it quite a bit. We could certainly pull what data is available in it, so we can see that.
When will the cost and utilization components of the survey be available? Because I think that could be very useful information for our group as we, start to wrestle with cost trends. Is that going to be available in the summer, Sarah? Or maybe Rebecca knows?
Yeah, I'm working on drafting the new dashboards right now. So we're working on getting all the data in. It's loaded. It's just building all the visualizations and the controls. So I'm hopeful that it'll be July or August. We'll have those published and up on the web.
Could we get a link to that at some point so that those of us that want to dive into that data and see what that looks like could do so?
Yes, there is a link to the dashboard in the slide deck. That
That's
one
right.
slide that
Okay.
had the 4 buckets had the link on it as well,
Yes.
and the cost data will be in the same place when it goes live. But we
That's
can
right.
definitely send a follow-up once it goes live.
Okay, good. All right, well, look, we're about 4 minutes away. So thank you again, Rebecca, for your time. And thanks to everyone for their participation this morning. Just a reminder that we are meeting again in July, toward the end of the month, I believe it is. And we also have a Medicaid waiver workshop coming up on Wednesday of this week for anybody who might want to participate in that. And Sarah, is there a way for us to find that? I can't recall.
In the email I sent you last week with the committee materials, there was an invitation to the Medicaid workshop included. We can send that out again today as a follow-up if that would be helpful.
I don't know if we need to. I mean, if it's there, people got the material. So good. Thank
And
you.
Jeremy, do you want to make any other pitches or comments about the waiver workshop?
Yeah, good.
We have a waiver workshop on Wednesday, half-day workshop on some of the key areas that we're considering for the waiver. So anybody's welcome to attend if they'd like. We are, expecting to fold in the cost per target as part of our conversations with CMS, particularly as we're thinking about moving them further along the spectrum to global budgets, any opportunities for sort of shared savings with the federal government. So that's that. We can send the information around folks who are interested in attending. I did want to make two other quick announcements since I've got the mic here. One, when we were given accolades to Sarah about her presentation skills, I failed to mention earlier that we've done some reorganizing within my team as we're implementing this program, have built out actually a team for implementing it, and Sarah's been promoted into the manager of that team, which is great. And then secondly, excited that Jessica Gomez was appointed by the governor and confirmed by the Senate recently to the Oregon Health Policy Board. And so we have a long time since we've had an employer on the Health Policy Board, and really excited that Jessica will bring that continuity of these conversations to the board.
Awesome, Jessica. Thank you for doing that. It's great. And congrats to you, Sarah. Okay, well, if there's no other business, then I think we'll go ahead and adjourn this meeting. I want to thank everybody again and all the staff for the great prep. Michael and Megan, always great to see you. And we will see everybody again on July 26th at 1 p.m. It'll be an afternoon meeting. And in the meantime, everybody stay safe and try to enjoy summer as it unfolds. Okay, I think that's a wrap.
Thanks, everyone.
Thanks all.